Good afternoon. My name's Chelsea Menchin, the National Projects Director at Palliative Care Australia, and I'm here to welcome you to the National Palliative Care Standards Community of Practice webinar series. In the spirit of reconciliation and allyship, I would like to acknowledge that we're all coming together today from the many and varied nations of Aboriginal and Torres Strait Islander people across Australia. Today, I'm sitting on the lands of the Ngunnawal and Ngambri people here in Canberra, and I'd like to pay my respects to elders past and present. Across both the National Palliative Care Standards for specialist providers and also the National Palliative Care Standards for all health professionals and aged care services, there are 9 standards. And across both sets of standards, there's consistency in those 9 standards. They're just kind of at a different level. So the expertise today will bring together the perspectives from across different care settings in response to both sets of standards. Today we're looking at Standard 1, and that's about assessment of need. And what you can expect to hear about today in the discussion is some practical insights for ensuring timely assessment of need for the patient, but also the carer's capacity to support the patient, and the importance of continued reassessment of these things over time. Kate Ritchie, Palliative Care Australia's Senior Project Officer, will join us and quickly recap the previous webinar that we had last month in this monthly series. And she'll go over what's involved for the community of practice and how you can get involved with that. And then she'll take us through the intent of Standard 1. Following that, we have some wonderful panellists who will discuss the elements of the standard and how that can be embedded into day-to-day practice. So really practical stuff. And we'll follow that with a Q&A from all of you, our audience. But for now, I'll hand over to Kate Ritchie for her to give you her insights from the last webinar.
Thanks, Chelsea. Good afternoon and welcome to everyone joining us online today. A special welcome to our community of practice members. These webinars have been designed for you to support you in your role, wherever that may be. If you haven't had the chance to watch our first webinar and would like a more comprehensive understanding of the National Palliative Care Standards and PACOP, you can access the recording by accessing the QR code about to appear on your screen. In that session, Chelsea and I were joined by Andrew Alsop and Dr. Claudia Verdun, where we explored how both the National Palliative Care Standards and PACOP articulate what high-quality palliative care looks like in practice. The intent of the standard is a series of statements. My apologies, I had the wrong slide on the screen. That is the QR code for the last recording. And we are now just going to go into the intent of the standard, which is a series of statements that provide further detail and explanation to assist with interpretation. For Standard 1, accurate, comprehensive, and timely assessment is fundamental to shaping a person's healthcare experience, no matter what the setting. Assessments guide clinical decision-making and influence how care is delivered and perceived. Standard 1 of the National Palliative Care Standards articulates that the person, their family, and carers are actively involved in the initial and ongoing person-centered assessment, which focuses on their physical, psychological, cultural, social, and spiritual needs. A comprehensive and holistic assessment of the person's needs and references and preferences is established on presentation and in early consultations, with assessment guided by the person. As more than one clinician may be involved, care is taken to ensure that assessment is coordinated and the information gathered is communicated effectively among the treating team and documented through digital health records. Reassessment should occur regularly, particularly as in changes of phases of care. These include identifying when the person is imminently dying and incorporating assessments of specific needs associated within this phase. The life experience of the person, their family, and carers will influence their preferences as they approach the end of life. These experiences may be shaped by age, culture, religion, ethnicity, or personal history. Some people have very deep attachments to such aspects, others less so. Consideration of the physical, psychological, cultural, spiritual needs and experiences are an integral part of initial and ongoing assessment. The person's care plan and any changes that may occur to it are directly informed by a comprehensive and holistic assessment.
Okay, so how do we ensure that the intent of the standard is met in our day-to-day practice? To do a deep dive into Standard 1, we'll invite onto the screen Kylie Draper and also Laura Bryce as panel members to talk about the elements of the standard and how they can be embedded in day-to-day practice. Kylie Draper is the Manager of Quality and Innovation at the Palliative Care Outcomes Collaboration, otherwise known as PCOC. Kylie is a registered nurse who has worked in palliative care sector for over 30 years in both nursing posts and senior executive roles. Kylie is the Secretary of the Palliative Care Nurses Australia and also sits on a range of other clinical governance roles both within and outside palliative care. Kylie was awarded the 2025 Noala Flynn Award for Excellence in Palliative Care Nursing by Palliative Care Victoria. Laura Bryce is the Palliative Aged Care Outcomes Quality and Education Manager. So that's known as PACOP. Laura has over 12 years' experience as a registered nurse and has worked across all areas of health service delivery, including tertiary hospitals, primary care and aged care settings. During this time, Laura has developed a passion for education and quality improvement. Welcome, ladies.
Thanks, Chelsea.
Thank you for having us.
So before we do a deep dive into the elements of Standard 1, we like to always ask our panellists an early question about their familiarity and when they first found out about the National Palliative Care Standards. So Kylie, you've been working in the palliative care area for 30 years. The standards have been around for about 20 years. When do you first recall finding out about the standards and how have they influenced your practice?
I first recall hearing about the standards when I was working in community palliative care, and we were using the NSAP program to measure how effective our organisation was at the time at meeting the national standards. So that's when I first became aware of them. Prior to that, obviously they weren't around, so there was nothing to be too aware of. But probably about 20 years ago.
Yeah. And Laura, how did you first, how do you promote the standards to someone learning about them perhaps for the first time?
The way that we promote the standards, particularly in the aged care context, is that They encourage aged care providers and care teams to review their current policies and process and drive continuous quality improvement so that they're working towards achievement of the standards over time. So they're an extension of what's required in the Aged Care Quality and Safety Commission's new palliative and end-of-life care domain, but we should be striving to achieve our best practice standards through the Palliative Care Australia ones.
Kylie, can you provide a bit of an overview about the Palliative Care Outcomes Collaboration, so PCOC, and how the project can be used by services to support the assessment of need standard?
Yes, so the intent of Standard 1, when we look at the standards, is that the person is in receipt of palliative care and their family are assessed holistically in a coordinated fashion. The person's physical, psychological, spiritual, social and cultural needs should all be addressed through comprehensive holistic assessments, supported by the systematic use of validated systematic tools. The PCOC framework offers 5 core tools at the moment currently that enable clinicians to assess patients and families in a holistic way. Symptom Assessment Scale, the SAS tool, is a patient-reported measure of symptom distress. The Palliative Care Problem Severity Score is a clinician-reported problem severity in the domain of pain, other symptoms, psychological, spiritual issues, and family carer issues. The RAG-ADL is a scale to measure the person's functional dependence, and the Australian Modified Karnofsky Performance Status, also known as the Karnofsky, assesses overall performance status. Then we've got the phase tool, which classifies an individual's palliative care trajectory, which is used to describe the distinct stages of the patient's journey and informs our response. So these tools directly support element 1.3 of the standard, ensuring that assessments capture the breadth of patient and family needs. Importantly, version 4 of PCOC, which has just recently been launched, will replace the SAS tool with the Edmonton Symptom Assessment System, the ESAS PCOC, which expands coverage to include anxiety, depression, and a global wellbeing measure, which will offer a more holistic perspective. There will also be the introduction of a delirium measure, with a clinician-rated one and a patient-rated one, so there'll be 6 tools in total. So this PCOC framework embeds consistent and regular assessment into care delivery, and tools are applied at key points of care. In a community setting, it's at the initial comprehensive assessment and at each visit, whether that's face-to-face or via telehealth, and whenever the patient's condition changes. And in the inpatient setting, it's at admission daily and whenever the patient's condition changes. So a systematic approach enables clinicians to identify the patient's phase of illness, whether they're stable, deteriorating, or terminal, and it allows the clinician to ensure that care is responsive and aligned with the evolving needs of the palliative care patient, which meets element 1.4 of Standard 1. And while PCOC produces outcome reports and dashboards for over 240 participating services and national and state reports to enable benchmarking across jurisdictions and against national standards, its primary value lies not in data collection, but in enabling consistent, structured assessments and guiding the appropriate clinical responses across the sector.
Yeah, fabulous. And also too, it creates that consistent language across the sector too, doesn't it? Laura,
Absolutely.
can you let us know how PCOC might differ from PACOP? So what's the difference there, and why is that difference important?
Absolutely. So PACOP, for those of you who aren't aware, evolved out of a trial of a modified PCOC framework in the aged care setting. So this was prior to COVID, and what it revealed was the need to take that step back in the resident journey and really help and build capacity in the workforce to recognise the deterioration and the identification of palliative and end-of-life care needs within those older persons. The first program component supports staff to recognise this deterioration and the need for palliative care through routine assessment and screening. As care models are shifting and people remain at home in their community much longer, residential aged care staff really need to be supported supported to detect those small changes in baseline and in deterioration over the time. So the identified needs then for those people who have palliative and end-of-life care needs recognised, they then move into the second component of PACOP, which is very similar to the PCOC model. So we do daily monitoring and regular assessment, which is tailored and responsive to the individual needs using a whole of team approach. Our implementation also evolved. Our workforce is very different in the aged care sector. So we have a lot of workforce mobility, and we have a lot of variance in the sizes and resources across aged care providers as well. So the traditional train the trainer approach needed to be adapted, and so we use a blended learning and a communities of practice model to build capability within the workforce and do mentoring. These adaptations ensure sustainability and feasibility in the aged care, but the core intent and quality improvement of outcomes remains the same.
Excellent. So Kylie, back to you. If we look at element 1.1 of the standard, it states that initial and ongoing assessment are carried out by qualified interdisciplinary personnel. What's PCOC's protocol for clinical assessment and response, and who can access or use that protocol?
So we have an assessment and response protocol because in palliative care, we're very good at assessing patients and families and carers. It's very important that we're not only good at impeccable assessment in line with the World Health Organization definition, but that we also have appropriate responses to that assessment, that we know what to do when we complete all the assessments. So the PCOC assessment and response protocol is really designed to provide that guidance and support for clinicians. It guides clinicians on how to interpret the assessment findings, how to respond appropriately, and how to ensure that identified needs, for example, pain, distress, carer strain, trigger timely interventions and also result in appropriate care plan adjustments and documentation of that. It supports services in meeting element 1.7 of the standard in that ongoing assessments inform care planning and changes. The protocol lays out the idea of screening for symptoms and problems, which is what our tools do. And once you've screened for symptoms and problems, it's not like you screen, you find a problem, and then you just don't do anything with that information. Very often, the screening will lead to more comprehensive assessments, so like more comprehensive pain assessments, etc. So the protocol lays out the idea that you need to screen for symptoms and problems. You need to monitor changes in response to those symptoms and problems that are identified in an appropriate and effective way when they're identified. I think the beauty of some of our tools is that they're not just being identified by clinicians as issues, they're patient identified. The protocol's available on the PCOC website, and it can be used by anyone who is using the PCOC tools. And even if they're not reporting their assessments to PCOC, they can still use the assessment and response tool.
Yeah, still use that evidence-based tools. So Laura, for you, for the first element of the Standard 1 in the National Palliative Care Standards for all health professionals and aged care services, it states that the initial and ongoing assessments are carried out by qualified health care professionals in partnership with members of the care team. How can the broader care team be empowered to recognise decline and prompt assessment or reassessment, including those in non-clinical roles? So that might, in an aged care setting, that might include personal care workers, people serving meals, people taking trays of uneaten food away, and identifying that for others to know what to do and to reassess.
Absolutely, Chelsea. So for us, particularly in PACOP, our assessments begin from the point of admission into the aged care home. And so that's really crucial that the residents are informed, that the staff have these skills, that we have these conversations regularly, and they're expecting those conversations to occur. So staff receive role-specific training to recognise and respond to deterioration within their expected responsibility and scopes of practice. So the aged care workforce really differs significantly from acute care and community care settings. 2021 census data showed that 48% were comprised of care workers, 18% were from nursing disciplines, and only 6% were allied health. So training is offered to all staff with strong engagement across their role. Care staff complete elements such as the SAS, and they're trained specifically in how to monitor that for psychological, psychosocial, physical changes and escalate those concerns appropriately to nursing for clinical review. So a clear response protocol defines the roles within the care team and ensures that timely escalation and referral fosters empowerment through clarity and tailored training. Effective implementation relies on clear processes and communications into daily practice. So that's how they can translate knowledge into practice. Over half of the workforce in aged care is from COLD backgrounds, and staff often report lower confidence in communication, and that's within their external and their internal teams. So strengthening communication skills and having processes that support and encourage regular communication really fosters that empowerment within the workforce. Providing a shared palliative care language across programs like PACOP and PCOC supports that communication across the whole multidisciplinary care team.
Yeah. And that's critical when you've got transitions of care too, isn't it? That people really know what they're talking about when they move from an aged care setting into hospital or vice versa. Kate, would you like to hit these ladies up with some questions? Oh, I think you're on mute. Said no one ever since 2020.
My apologies. Yes, so Kylie, the second element of specialist standards states that the assessment is coordinated to reduce the burden of duplication on the person, family, and carers. How does PCOC support a coordinated approach, and why is a coordinated approach important?
So I talked before about the assessment and response protocol that provides a framework that's consistent around the country, thereby creating the common language. And Chelsea alluded to this before, that is spoken in many palliative care settings and across settings. So it's a PCOC language. A common multidisciplinary language or interdisciplinary language strengthens communication, which always improves continuity of care and collaboration across settings of care. So if you're sending a patient from the community into an inpatient setting and you're communicating in a PCOC language, it's very clear for whoever's receiving that person how they're going to find that person, what phase that person's in, what are the primary issues. So that common language promotes that continuity of care. This standardisation means that all participating services are using consistent tools, which enables that common language. And it helps readers and many others collected. Is everything okay?
Yeah, we just had a little bit of a lag on your description there.
Oh.
Keep going and we'll see how we go.
Okay. I was just saying that the common language helps to reduce variation and duplication across care providers, and the PCOC assessments are integrated into care pathways and IT systems around the country, which helps to ensure that the information is collected once and shared across the team. This will be strengthened with version 4 of PCOC and the completion of many unchanging data items once at the initial comprehensive assessment, and not repeated at ongoing assessments. The holistic nature of the tools help to prevent repetition or fragmented assessments by different disciplines. In the interdisciplinary teams, in the collection of data, which enhances the quality of care for patients and lessens the burden for patients and families. Hopefully I wasn't too laggy, everyone.
A couple of gaps, but I think I do think we all would have got the message, so that's okay. Kate, did you want to direct one to Laura? Yeah. Are you in charge of your muting? You might not be. Okay. Laura, can we look at that same element from the non-specialist providers? What impact can duplication of assessments have on residents and their families or support networks?
Yeah. So when we train aged care staff, we look at integrating components of the assessment like SAS into their daily routines and conversations. And this is why it's so crucial we have a whole of team approach. So creating opportunities to connect with residents, revisit discussions for clinical review and build meaningful relationships is really important for the whole team. So good assessment drives good care. And under the new Aged Care Act, communication expectations are high, ensuring transparency and autonomy is delivered through a rights-based approach. PACOP and PCOC shared language and tools help reduce the assessment burden by providing comprehensive clinical histories, measurement of changes over time, and an alignment with the individual's needs, wants, and preferences, fostering that person-centered care and trust. Feedback from some of the aged care homes that we actually work with that are using PACOP have shown to us in some anecdotal feedback that they've actually had a reduction in their complaints by strengthening those communication pathways and trust and transparency with individuals and their supporters. So while spiritual support is common in aged care, often the gaps that we find are in those allied health services and referrals, especially around things like social work and bereavement services. So duplication of assessment and advanced care planning conversations, family conferences, those repetitive conversations can often lead to psychological or psychosocial symptoms or distress and complex grief. So being aware of those impacts, monitoring through the holistic assessments and helping to identify and respond to those issues early by prompting these caring conversations and appropriate supports is really important.
Fabulous. Kylie, we'll just quickly go to the third element. That looks at clinical assessment being informed by the best available evidence and identifying those approaching the end of life and those who are imminently dying. So how does PCOC help services achieve this element, especially in supporting the non-specialist providers to recognise that someone is approaching imminent death?
So the PCOC framework encourages clinicians to determine which palliative care phase that the patient is in by applying all of the tools. The terminal phase, also known as phase 4, is assigned when death is likely within days. This helps the team to focus care on the delivery of appropriate terminal care to the patient. Determining that the patient's in the terminal phase may also like contacting the GP and letting them know that the patient's in the terminal phase, having conversations with family members and the patient around where they're at in their illness, maybe ascertaining the person's funeral plans if that isn't already known, doing some hurried advanced care planning if that information isn't in place. So identifying the terminal phase is really important. It ensures preferences regarding site of care are known and documented, and that communication with family and friends is really critical. The PCOC team provides supplementary data to services that participate as well, and I really see this as a treasure trove of information about services and about individual patient outcomes. So in that data, there's information about every patient in your care who died outside of the terminal phase. So that is patients who died in another phase, like the stable phase or a deteriorating phase or an unstable phase. And it's fair and reasonable that there will always be a proportion of patients who will die outside of the terminal phase. They may be patients who die unexpectedly, for example, in their sleep without experiencing a terminal phase or active dying. However, some services may find in their supplementary data that there's a pattern of a significant percentage of patients dying outside the terminal phase. And this offers an opportunity to the services to audit those patients and to determine if the dying failed to be recognised, or if there was a reluctance to call a terminal phase, because sometimes more novice clinicians or clinicians that work outside the specialist space might not trust their gut around what they're seeing in front of them, or trust the tools that they've completed. So an increasing RUG-ADL score and a decreasing Karnofsky score indicate a reduction in performance status and an increase in functional dependence. And these are poor prognostic indicators. And one can often see when auditing a file like this that it was evident that the patient was approaching death and entering a terminal phase. And then this can lead to QI projects that, for example, work with clinicians on recognising when a patient is dying, build their confidence, especially if they're new to palliative care or they're working in a generalist field, and ensuring that documentation reflects the phase correctly. Sometimes also, as a smart manager, you might need to engineer processes to encourage recognition of dying. So, for example, patients that enter a terminal phase might be offered overnight respite. And if they're not correctly phased, then they won't get the resources that are required. So that encourages clinicians to make sure that they're phasing patients correctly.
Fabulous. Kate?
Thank you. So, Laura, there are many electronic medical record systems across aged care settings. How does PACOP support the documentation of a person's need and communication across the multidisciplinary team?
Great question. There are indeed a lot of care management software systems, or the care programs we kind of refer to them as. So PACOP provides a structured approach to collecting and collating clinical assessment data. So documentation includes electronic assessments, and we provide software freely available to participating homes, and we're working on a cloud-based system at the moment. Part of these systems allow staff to directly enter the assessments at the point of care, and this supports communication across care teams, informs case conferences, clinical rounds, drives quality improvement, and it can be reports that are then generated at the individual resident level, at facility or organisational level. So PACOP mentors teams through communities of practice to strengthen communication skills and to integrate assessment and care planning actions into things like their handovers, needs rounds, referrals, standardised techniques like ISBA, and we also collaborate with the IT vendors to embed assessment tools within these clinical management software systems, reducing the duplication need across IT software and aligning with the Department of Health's digital health roadmap. So this will improve accessibility and, more importantly, the clinical usefulness and access to that information to ensure that we can action and respond to care appropriately, both within the facility and externally.
Okay. So we've covered off the first three elements of the standard one, assessment of need. We'll just have a quick look at the fourth one, and then we might go to Q&A. So the fourth element looks at reassessment, and this is one I don't want to leave off because it's so important. It's definitely not a one and done thing. So the fourth element, looking at reassessment, PCOC has 5 assessment tools to be used as a suite. Can you talk about these assessment tools and why using them as a suite is important?
Yes, thanks, Chelsea. It's important to use the 5 tools together for a variety of reasons. So speaking firstly about the SAS or the ESAS for version 4 of PCOC, the gold standard is that this is patient-reported distress or severity of symptoms and problems, and it ensures that the patient's voice is central to assessment, highlighting what is most bothersome for them. And tracking this over time also provides the clinician with an opportunity to determine if their interventions and their care plan have been effective or not from a patient's perspective.
Oh, I think we've got lag again.
Psychological. Sorry.
That's
yeah,
okay.
We're having a little bit of in and out here.
We are. Do you mind if I kick this one to Laura? So from the PACOP perspective, can you explain how PACOP supports early identification of deterioration and the need to commence palliative care?
Yeah. So as I mentioned, Chelsea, assessments begin at the point of admission. And they continue until the person's final days. So with routine reviews occurring at least every 3 months, this allows us to monitor their baseline function and performance and symptoms over time and prompt advanced care planning discussions that can be revisited. So additional screening occurs then when clinical concerns arise. The primary need for care in residential aged care is often advanced frailty or dementia in our data. And really the baseline monitoring is essential in those populations because often it's the subtle changes that signal that progression towards end of life, and the ability to draw on multiple sources of clinical data and across the team because they'll all have different perspectives and expertise. So using those observations and skills, looking at things like assessments, quality indicators, hospital use, infections, falls, SIRS, staff observations. There's so many rich opportunities to observe changes and escalate deterioration. So that early recognition enables clear communication within the teams, but more importantly with the individuals and families as well. So ensuring that person-centered palliative care is provided and that we have those caring conversations frequently throughout the admission. So once the palliative care is commenced for that individual, we begin daily monitoring using the SAS, and then we have daily or weekly clinical reviews as needed, or daily or weekly. And that really then allows us to coordinate with either the primary palliative care or the specialist palliative care team to ensure that we're promoting equitable, assessment-informed need to access palliative care.
Yeah. So we might go to some of the questions from the audience, and we've got a couple of good ones here. The first one I have is actually about the support at home program, which isn't surprising because that is something that's on everyone's minds at the moment. So Laura, I will direct this one to you, but you also may have views, Kylie, in the context of practitioners working with people who are reaching end of life under the support at home program. So the end of life pathway, what validated tools could be used by doctors and nurse practitioners? And is there a tool used to help estimate the 3-month prognosis?
Good question.
It is a very complex one.
It's a very complex question, and I think too that this is what we were saying about the variance in providers and the resources and the awareness that they have in their model of care and within their organisation. So I think when they're looking at validated assessments, as Kylie said, they can access the PCOC assessments, they can access PACOP assessments. There's a variety of tools available. We've got a PhD student at the moment who's working to modify a version of PACOP so that it's specifically for those older persons living in the home-based community aged care settings to identify palliative care needs and then coordinate that response. So within that, we do see tools like PCOC, PACOP, SPICT, those types of things. And I think it's really a gap at the moment for support at home, particularly where we've got this idea that the workforce needs to then not only recognise that the person has palliative care needs, but also then if it's a primary palliative care being managed by the GP or if it's a specialist palliative care need and they need to engage with specialist palliative care services.
Yeah. Did you want to add to that, Kylie?
Yeah, look, I agree. I think that some of the tools could be very helpful in the generalist setting and could readily lagging child.
Yeah. Okay, we might go on to the next question. Sorry, again, Laura, it's directed to you. How can people find out if any of their RACF facilities, so residential aged care facilities, are using PACOP? How do you know if people are, is there a register somewhere?
Yeah, so look, PACOP has approval, I guess, to run a list of services. Because we are so new in establishing our data sets, and we've just started to release some national data on our website, we haven't actually released publicly a list of services who participate in PACOP. That is something we're talking with providers and with the sector around how they feel about that, particularly as we know the rhetoric that has happened in the media previously around star ratings and the accreditation processes they have. So we really work with them to see that in a positive light, and that it's a commitment for them for quality improvement to openly say that they're doing PACOP. The biggest thing I would say is to have a talk with your facility or with the provider as well. So ask them, have a conversation. Have they heard of PACOP? Have they considered doing it? And oftentimes too, we have a variety of engagement and homes that are using PACOP. So perhaps they're using it clinically, perhaps they're submitting data and getting reports back, perhaps they're aware of us, and continued reform as well has meant that PACOP as a voluntary program has been on their agenda, but not necessarily their key priority as that reform came through. So sometimes too, it's also around the IT release. And as I mentioned, with our new IT platform, we've got a variety of people who are saying, yes, we want to do PACOP, but we're waiting for it to come into our clinical management system to reduce that perceived burden of duplication of documentation on the staff. So really, I would just say have a conversation with them, and two, reach out to us and get in touch with our improvement facilitators. So we have improvement facilitators that are based in all states and territories, and they have really close relationships at organisational levels and at the site level. So they can probably give you a good understanding of what's happening across PACOP with the aged care homes in your region or that your services cover.
Fantastic.
I've got another question, and I think this could be aimed at yourself, Kylie, or Laura, but it is, how can clinicians recognise and integrate the wishes of carers who are often advocating on behalf of terminally ill persons who are no longer able to express their own wishes?
That's a good question. So part of what we do is we do proxy assessments. So if a patient's unable to complete any assessments, we can on behalf of the patient, from the patient's and families, in helping to identify troublesome problems or symptoms. In palliative care, we certainly encourage that the carer and family unit are included as much as possible and as much as the patient wants, as directed by the patient.
Yeah.
Kate, can I add on to that from a aged care perspective, particularly where we have our residents who have cognitive impairments or advancing dementia? So often we will refer those situations back to needs, wants and preferences, advanced care planning discussions. And this is part of the importance of that first component of PACOP, where we're setting that expectation and those discussions right from the point of admission, so that wherever possible, these conversations are happening multiple times, and we can use them to review what was expressed by that individual at that time, and use that to centre those discussions on. There's also some great resources with places like Advanced Care Planning Australia and OPAN as well around advocating for those individuals.
Yeah, and we've certainly talked previously in National Palliative Care Week last year, we were talking about advanced care planning and how there is sometimes a bit of apprehension to jump into advanced care planning when someone first enters residential aged care. But it really is as simple as saying, now that you live with us, what can we do to make sure you get what you need should you become unwell? You know, like, so it doesn't have to be about end of life. It's just about, should you become unwell, how do you want this to work for you? Yeah.
Absolutely. And that's probably a lead into some of our resources that we have available, especially the discussion starters, which are an excellent way of just looking at how we frame our questions and asking those open-ended questions. What is important for you? Often just tweaking the way that we say things can be very impactful on the patient and or resident and the family or carer's experience.
So I've got one more question. What are some practical ways that clinicians can ensure assessments are genuinely led by the person and their family rather than by the service and what might seem more efficient for the service to operate?
I think that there's a variety of resources. Did you want me to answer? Can you hear me okay?
Yeah, go for it.
Yeah, okay, good. There's a variety of resources that we produce that with patients easier. We have visual analog scales, which have the faces on them. People might have seen them, they're rulers, and they can help patients. And I've found in my clinical practice that they're particularly useful for people from culturally and linguistically diverse backgrounds, and also children and adolescents who maybe find it hard to put a number to a problem or a symptom, but it's easier for them to put a face to a problem or symptom. So those rulers are readily accessible on the internet, and you can order those resources from PCOC as well.
What about it from PACOP perspective?
So Chelsea, I think this ties into that idea that some of the assessment components we're doing already in our usual practice. We walk into a resident's room in the morning and straight away we're saying, hey, Bob, how did you sleep last night? And we're having those conversations genuinely from a place of caring and connection. And so I think where those conversations occur in everyday habits within the aged care home, it's really about noticing those changes and then escalating that up and having that as the opportunity to revisit those conversations and be guided by what's impacting them. And we talk about this a lot when we talk about things like the SAS and things like the problem severity scale, particularly in an aged care population that has this beautiful combination of complex and acute problems, and they're quite stoic and they don't want to be a burden, and the workforce is short-staffed, and we have all of these complex factors, but really tapping into what's impacting them the most and how can we improve that meaningfully for them is really important. And that's going to make the biggest difference for residents, and their families and carers see that too.
Yeah. And I guess that's good patient-led assessment, isn't it? So how can assessment questions be framed to support self-determination and to build trust with Aboriginal and Torres Strait Islander peoples and families? I might kick this one to you, Kylie. I know that that's an area of special interest for you.
Sorry, Chelsea, were you talking to me? Can you just repeat your question?
Sorry, yes. So for Aboriginal and Torres Strait Islander families and people that are in care, how do you support self-determination and build trust so that they can express their needs for assessment?
Well, I think having open conversations with people, having the right people in the room, and just taking your time with people around what their symptoms and concerns are. I have found in my practice when I've worked with Aboriginal and Torres Strait Islander people that very often the numerical rating scales don't work very well. So once again, using the faces and the visual analog scale can be quite useful to help elicit that information around severity of symptoms and problems. But certainly just working with the patient and the family, being respectful and having the time that is required to complete these assessments, because sometimes they take time, but they do give you a really good baseline and help identify what is bothersome for the patient might not be something that is bothersome for them. I remember distinctly working with one patient, and I asked her how much information she wanted us to be sharing with her about her illness and how it was progressing. And most people would say that they would like to know everything. This patient clearly said, I don't want to know anything. She rated it 10. I don't want to know anything. I'd prefer that you keep the information very minimal. I'm really not interested in hearing all of the details. So it's important checking in with people to find out what their capacity is absorb some of our questions, because sometimes we have a lot of questions, and it's not always helpful for the patient to be asked a lot of questions.
Yeah. What about in the aged care setting, Laura?
In the aged care setting, look, I think we really need to be mindful of how we have these conversations, having them respectfully and listening as much as we can, being led by that individual and by who's important to them, as Kylie said, mirroring that, who's in the room, who's important to them. That's really something that we need to be aware of and make sure that we're being led by that, what they want, and building trust and time.
I think we'll just have one more question that you both can answer, and then I might get Kate to explain some things about the community of practice. So for a final question, what are some small changes that services can make to embed patient-led assessment into everyday practice? Kylie? Can we take Kylie off mute, please? Sorry. Laura, do you want to start answering that?
Yeah. So sorry, that was around how to implement patient-led practice into every day.
Yes.
So I think really it's around reflective practice and thinking around what makes the importance for patients or residents. What are the processes you already use in your workforce or within your team? What works well, what doesn't? Where can you improve that? So I think when we're talking around implementing patient-led assessment, it's also around the processes of how we use that information. Because when we see the value in it, and when residents see the value in it too, it changes from a tick box or a activity we're doing because it says you're due for your care plan review, into something that's much more meaningful and valuable for both the staff and for the person who's receiving care and their family.
Beautiful. Kylie?
I think the patient voice and the carer voice is critical, and you always need to bring it to the table. We should always be working around the family and the patient and their wishes. Recognising also that there's a lot of people around the country that don't have a carer and that are living alone. So trying to make sure that the way we design assessment tools are often consumer-led, that we're having consumers involved in the development of these tools, and that they're co-designed so that they are considering things from a patient's perspective rather than just the clinician's perspective.
Perfect. Now, Kate, you've established the community of practice for the National Palliative Care Standards just over the last couple of months after a light bulb moment at OPCC 25. I want to give you an opportunity to explain to anyone that's not already involved in the community of practice what it is and how it works and the resources you're providing for them every month.
Okay, so the community of practice is a collaborative space for learning where members can ask questions, share reflections, and exchange service stories. So it's all centred around the National Palliative Care Standards as well as PACOP, which is the self-assessment. To support this, there's a dedicated Microsoft Teams channel that is set up as a forum. So that's where you can post reflections, ask questions of the community. There was a little bit of confusion in terms of using the two platforms for the live webinars. So the live webinars are used in StreamYard. If you go into the community of practice reminders each month, on that calendar, there should be a link so you can go in and come through onto this platform. And that just to make sure that we have a really good quality recording and that you can watch it on demand as well as live. Each month there will be an infographic which can be displayed within your service to have discussions to bring the elements of the standards to the forefront of the mind and think how we can embed it into our practice every day. And there will be an article that you can distribute in newsletters, blog posts, however you communicate within your setting. And that is going to come out each month to support you and your service in embedding the standards into your day-to-day practice.
Wonderful. And also too, with each month, Kate has mapped some of the national resources that are useful to you when you wish to embed the certain standard that we're talking about that month. So that's a really good way to find out about the resources like PCOC and PACOP, but all the other resources out there that are available to you for free and to you and your teams. So we might just take that slide off and go back to the screen for all of us. The best way to stay up to date with what's happening around the National Palliative Care Standards Community of Practice is to join the Community of Practice. And if you're already on there, please don't be shy. We want you to share the examples, just as Kylie and Laura have here for us today, so that people can hear how other people are embedding standards into their day-to-day practice. And even attending, like joining into the Community of Practice and attending these webinars and learning from other people actually go towards evidence towards standards 7 to 9, which are all about staff qualifications and training and service culture and quality improvement. So you're already stepping in the right direction. So we've just put up that link to the Community of Practice, and it will also come out again in an email after this. So as Kate mentioned, we do have these live webinars each month. And from January, I just want to let people know that we won't be doing a live webinar in January. We will actually be uploading some information to the Community of Practice on the standards more broadly. And Kate will also do an infographic and a blog in January, but we won't have a live one because we want everyone to have a break if they can get a break. So our next webinar will actually be on the 18th of February with a focus on Standard 8 for quality improvement. There will be a fourth speaker in that. We're just confirming those details now, so you'll see that slide on screen. I'd love to thank our speakers from today. So Kylie and Laura, thank you so much for coming along and sharing your experience and your understanding of the breadth of sectors that are involved in palliative care, whether it's a GP going into aged care or someone working in the acute care setting or community setting across aged care or community health. There's certainly learnings for everyone out of our discussion today, and thank you so much for joining us.
Thank you.
Now,
Thanks, Chelsea and Kate.
it was great to have you along. So we were hoping to see you all in February. In the meantime, thank you again for joining us today. And from PCA, we want to wish you all a safe and joyful festive season, regardless of what you're doing. Have a wonderful, wonderful break if you get one. And if not, then please have a wonderful time with family and things around work. Thank you, and we'll see you next in February.